This is the second lecture on the circulatory response to exercise. One of the themes is maintaining blood pressure, and one way that we do this is by maintaining blood volume. The hormone ADH, or antidiuretic hormone, is very helpful for this. It helps the kidney to conserve water, and that's actually allowed for humans to live in various environments, such as in the desert. In the last lecture, we talked about end diastolic volume, or EDV. That's the volume of the left ventricle just prior to ventricular systole, which includes this ejection phase, where blood would be ejected from the left ventricle. And then ESV, or end systolic volume. That's the volume of the left ventricle after the ejection phase of ventricular systole. So if we want to know what the volume of blood is that's been injected per heartbeat, we simply take EDV and subtract out the ESV, and that's what's called the stroke volume. It's the volume that's injected per heartbeat. Furthermore, if we can go one step further, we can ask what's the cardiac output. So this is the rate of flow of volume per unit time, and that's going to be calculated as stroke volume multiplied by heart rate. So for example, I could give you a problem such as this. Given an EDV of 120 milliliters of blood and an ESV of 50 milliliters and a heart rate of 75 beats per minute, what is the cardiac output in liters per minute? So to solve this, we first want to calculate the stroke volume. The stroke volume is 0.12 liters minus 0.05 liters. And then we're going to multiply that by 75 beats per minute. And we'll get 5.25 liters per minute. So our cardiac output in this case is 5.25 liters per minute. That's very close to the average value often given in textbooks of about 5 liters per minute for your typical adult. In a previous lecture, we talked about the mean arterial pressure, or MAP. MAP is extremely important because pressure is essentially the kind of potential energy that that's converted to kinetic energy, which is the energy of movement. So it leads to the movement of blood through organs. So it leads to organ perfusion. So it's incredibly important that the mean arterial pressure be maintained in a certain range. So typically it's in the range of roughly about 100 millimeters of mercury in your typical adult. And so mean arterial pressure is something that your body senses. It's a regulated variable, so it's under homeostatic control. The way your body regulates MAP, or mean arterial pressure, is through cardiac output, which we just discussed. It's the volume per unit time that is pumped by the heart. And the other thing is what's called total vascular resistance, or TVR. Total vascular resistance is the combined resistance to blood flow through all the various circuits that make up the systemic circulation. So if you think about it, there's all these arteries, then capillaries, then veins, and so forth. And so there's a sort of combined resistance of all these of those combined, and that's the total vascular resistance. Now, just to make things complicated, TVR is also called systemic vascular resistance, or SVR. So that's the term you'll see very often. TVR is also called total peripheral resistance. That's a little bit of an older term, but it's still very much in common use. So that's TPR. So unfortunately, you'll see this. I'm telling you this because you'll see this written many different ways. The book uses total vascular resistance, so I'll stick with that convention, which is perfectly fine. Now, the mean arterial pressure is simply the product of cardiac output multiplied by the total vascular resistance. And so anything that affects cardiac output will affect MAP, and anything that affects the total vascular resistance will also affect MAP. So let's look at an example. So for example, think about the idea that you might have an increase in blood volume. This may happen if you retain extra water. This will lead to an increase in blood pressure. Also, if you have an increase in heart rate, remember that heart rate contributes to the cardiac output, and therefore an increase in heart rate, that will also increase blood pressure because it's increasing cardiac output. An increase in stroke volume. Remember, cardiac output is essentially the product of the amount of blood ejected per heartbeat, which is stroke volume, multiplied by the beats per minute. So if you have an increase in stroke volume, that'll increase cardiac output, and an increase here, as you can see in this equation here, will increase the mean arterial pressure. So all of those things will increase the blood pressure. Another thing that will increase blood pressure is blood viscosity. Now, this doesn't really change very often under most physiological conditions, but it could. If a person was, say, stranded in a desert with nothing to drink, their blood viscosity may go up as their blood osmolarity increases. In other words, the saltiness of their blood increases. So it is possible. And that could definitely have some effects on blood pressure. And then it's here again. This is actually TVR. Here it says peripheral resistance. What they're referring to is the total vascular resistance. So if that increases, that will increase the blood pressure. And you can see that here. If this increases, then since MAP is the product of cardiac output and total vascular resistance, then let's say this doubles, then the MAP would double. Of course, that'd be crazy. It wouldn't really double. But and how does that happen? Well, the blood vessels have smooth muscle associated with them, so they can vasoconstrict and vasodilate. And in doing so, they'll change the total vascular resistance. Your body has ways to regulate blood pressure in the short term. Let's use the example of donating blood. You give some blood up, and that leads to a decrease in blood volume. A decrease in blood volume leads to a decrease in MAP, or mean arterial pressure. And as I mentioned, that's a regulated variable. So that's something that's sensed and controlled through homeostatic mechanisms by your body. The sensors for blood pressure are baroreceptors. Baro refers to pressure. Think about barometric pressure. And receptors, of course, are neurons. And so they have endings that are sensitive to stretch. They're mechanosensitive neurons. And these baroreceptors are located in the aorta and in the carotid arteries on both sides of the body. So here there's only being shown one. Let's imagine that there's a decrease in blood pressure, which is consistent with the idea that you've given blood. Well, this will lead to a change in the action potential frequency of these sensory neurons. These sensory neurons send information to the cardiovascular control system, which is located in the brainstem. The cardiovascular control system will then affect things like sympathetic nervous activity. In this case, output will come through spinal nerves. So let's consider this. So this is a sympathetic ganglion right outside of the spinal cord. There's excitation here. Action potentials travel through a nerve in axons, and we have sympathetic nerve fibers that innervate, meaning they connect to the SA node. This is the sinoatrial node, and this is the pacemaker center of the heart, located in the right atrium. They'll release norepinephrine, which is an excitatory neurotransmitter, and this will cause an increase in heart rate. At the same time, other fibers will release norepinephrine onto cardiomyocytes that are involved in the contraction. And these are cardiomyocytes within the right and left ventricles. And what will happen is if they receive excitatory input via this pathway, this norepinephrine will increase the contractility of the heart, meaning that the contractions, when they occur, will be more vigorous. So let's think about what's happened now. So we've detected a decrease in blood pressure in the carotid arteries at the carotid baroreceptors, and also in the aorta at the aortic baroreceptors. In order to compensate for that, we're increasing the heart rate through the action of norepinephrine on the SA node, and we're also increasing the contractility of the heart through the action of norepinephrine on the cardiomyocytes of the two ventricles. So these changes will essentially oppose the decrease in pressure. So because there'll be an increase in cardiac output. And so that helps with bringing mean arterial pressure back to where it should be in its normal range. Let's imagine things go in the opposite direction. There are certain situations where you may have an increase in blood pressure. And so this will then activate the same sensory neurons, these baroreceptors. They'll send input to the cardiovascular control system. And now this will change output. So for example, if there's this decrease in blood pressure, there'll be, an increase in blood pressure, there'll be decreased sympathetic nervous system activity. And so we'll have less norepinephrine released onto the SA node, and therefore the heart rate will go down. There'll be less norepinephrine released onto the ventricles, and therefore the heart contractility will go down. So both of these things will decrease cardiac output, and therefore if you decrease cardiac output, that will decrease the mean arterial pressure. Now, one thing that's not mentioned in your book, but there's also controlled by the cardiovascular control system is also activity in the parasympathetic nervous system. So shown here in this diagram, you have an axons coming in the vagus nerve. And so this is part of the parasympathetic division of the autonomic nervous system. And these neurons will release acetylcholine onto the SA node or sinoatrial node. And what they do is they'll decrease the heart rate. Notice that there's no corresponding terminals of the parasympathetic nervous system onto the ventricles. So in other words, the parasympathetic nervous system doesn't directly affect the heart contractility, but it does affect the heart rate. So in the case of the blood pressure being too high, when there's an increase in blood pressure, you'll have a decrease in SNS activity, sympathetic nervous system activity, but you'll have at the same time an increase in the parasympathetic nervous system activity. And this will also contribute to slowing down the heart rate. In a previous lecture, you learned about ADH, or antidiuretic hormone. It turns out that this hormone is extremely important for the long-term regulation of blood volume and thereby mean arterial pressure. And so ADH acts on the kidneys, and it helps to control blood volume. Let's look at this example. Let's start off with a person here being dehydrated. Okay, so this is step one. This leads to an increase in osmolality of the blood plasma. Therefore, osmoreceptors, which are neurons within the hypothalamus, are activated. And one of the first things they'll do is activate a behavioral response, which is thirst. So you'll feel thirsty, and then you'll drink water. So this increases water intake. And you see this dotted line here. This indicates negative feedback. So this person was dehydrated. Now they're hydrating. So this will decrease the level of dehydration of the person. And it'll decrease the osmolality. Therefore, these receptors will be less active. At the same time, these osmoreceptors in the hypothalamus will activate will stimulate the release of the hormone ADH, or antidiuretic hormone, from the posterior pituitary gland. Recall that there are two parts to the pituitary gland: the anterior, which is a true endocrine gland, and the posterior pituitary gland, which contains the axon terminals of neurons that release neurohormones. And these neurons actually have their cell bodies located in the hypothalamus. So they're stimulated by these osmoreceptors. to release ADH from the terminals located in the posterior pituitary gland. So there's increase in ADH secretion. This then goes to the blood. It acts then on the kidney, and it increases the reabsorption of water. And so that also helps. The person is dehydrated, so what they want to do is make concentrated urine, not dilute urine. And so by doing reabsorption, you're able to conserve water. And you can see here that we have the dotted line again, indicating there's negative feedback. So the person's conserving water, and so that opposes the fact that the person is dehydrated. And so again, this is going to increase or help to maintain the blood volume. And by maintaining blood volume and not letting it drop too much, you also help to maintain the mean arterial pressure. And mean arterial pressure is incredibly important because it's the driving force. It's for perfusion of all the organs in your body. So if the mean arterial pressure drops, then that's really disastrous for your body. The next topic is the electrical activity of the heart. We've talked about contraction in skeletal muscle. And recall the preceding contraction, there was excitation, which was an action potential, which is a depolarization of the membrane of a skeletal muscle. Well, a similar process happens with the muscle cells of the heart. As we mentioned previously, there are different from skeletal muscle in a number of ways. But the general principle is similar, that they're going to have electrical activity that precedes the contraction. So you have excitation, contraction, coupling. Okay, in order to lead to contraction of the atria and ventricles, we have the beginning of an action potential in the SA node, the sinoatrial node. These are cardiomyocytes that have been modified to be pacemakers. So what they can do is they'll initiate a depolarization or an action potential over and over again throughout your entire life. Now these are modified cardiomyocytes, so they do have some contractile ability, but it's really very weak compared to your normal cardiomyocytes that are actually involved in generating strong contraction. So they will generate an action potential. This action potential can then spread throughout the atria via the intercalated discs that have gap junctions, which are electrical synapses. So recall that these cells are electrically coupled, and each heart muscle cell itself is capable of generating an action potential. So it has all the channels and ion channels and so forth to be able to generate an action potential. So the electrical signal will spread directly cell to cell that way, but there are also these pathways that allow for efficient movement, which are shown here, of this electrical activity or this action potential. So you'll note that electrical activity is transferred through a pathway from the right atrium, where it starts, to the left atrium. And the reason for this is ideally you'd like the two atria, they should contract in a normal healthy person simultaneously. And so that's what happens. They start to contract, and at the same time, electrical signal is passed. The electrical signal is called an action potential to the atrioventricular node, or AV node. So there's a little bit of a delay there. So remember, the atria have to contract first, so as they're contracting, the signal essentially slows down. The propagation of the action potential slows way down in the AV node. And then from the atria to the ventricles, because there's a fibrous skeleton to the heart, which isn't shown in this picture, but that prevents the direct movement of electrical signal from the atria to the ventricles. But there is a very specific pathway. There's this thing called an atrioventricular bundle, or AV bundle, also called the bundle of His, which is shown here. That actually passes from the atria to the ventricles. And so that's the only pathway for the electrical signal to pass from the atria to the ventricles. So after a bit of a delay, it passes down this pathway. It then goes to the atrioventricular bundle, which is also called the bundle of His. Then it goes into the two bundle branches, the left and right bundle branches. From there, the signal goes to the apex of the heart. Note that the apex is at the bottom of the heart. And then the electrical signal or action potential climbs up through the myocardium, through what are called Purkinje fibers. And so the contraction of the ventricles actually starts at the apex or the bottom and then moves up. So you can think of that a little bit like trying to get toothpaste out of a tube. You start at the bottom and you push upwards. And so the contraction does work its way up this way. And this is a very effective way of pushing the blood up towards the arteries where it should be exiting or being ejected from the heart. So one way of looking at the heart is through its electrical activity, through what's called an electrocardiogram or ECG. This records electrical activity of the heart extracellularly. And there are a number of markers we can look for. There's, for example, the P wave, and that corresponds to atrial depolarization. So we're looking only at the electrical events and not the contractile events. So you can imagine that what would happen after the atrial depolarization, there's a little bit of a delay because there's always a little bit of a delay between excitation and contraction. But essentially, after the beginning of this P wave, you'd have the contraction starting in the atria. The next major wave is the QRS complex, which is shown here, QRS. And this corresponds to the ventricular depolarization. And at about that time, the atria will repolarize. And so the atrial repolarization is a little bit hidden. You can't see it because it's happening at the same time as the ventricular depolarization. Recall that the ventricles are much more muscular and bigger than the atria. And so the electrical event in the ventricles is correspondingly bigger. And so it sort of swamps out the atrial event, repolarization. Now, so after this QRS complex, it's not shown here, but you can imagine that this is the depolarization due to the action potential traveling through the ventricles, starting at the apex and then moving upwards. And there's also going to be a wave of contraction that occurs after that. So it's roughly around this time. And then with a little bit of a delay, there's then the T wave. This corresponds to ventricular repolarization. So the ventricles will repolarize and the contraction will stop at that point. One common diagnostic procedure used to evaluate cardiac function is called a stress test. A stress test is an exercise test in which the intensity of the exercise is incrementally increased. The most common cause of heart disease is atherosclerosis. It's characterized by plaque in the arteries that reduces blood flow and also hardens the walls. So the general term for hardening of blood vessel walls is called arteriosclerosis. So it's a little confusing because it's very close to atherosclerosis. And it also is confusing because these terms are often used interchangeably, but they are different. Atherosclerosis is a type of arteriosclerosis, and it happens to be the most common type of arteriosclerosis. When a person is at rest, when you look at their ECG, everything may be fine. And the reason for this is blood flow may be sufficient when a person is at rest. But recall that during exercise, the metabolic needs of the heart may increase tremendously, by tenfold or more. And therefore, the oxygen demand is higher. So then if you look at the ECG of the same person, but now you're stressing them, having them, say, riding on an exercise bike, the ECG may start to reveal ischemia. So here, shown in this picture here, you see P wave, QRS, and T in a normal person. Everything looks fine. Now, all these things could say roughly the same. Of course, the heart rate will increase during exercise, but the overall shape should say roughly the same. But in a person who has ischemia in the heart, you'll see something like this: the P wave, the QRS complex, and then you see this ST segment, which is the time duration between the S and the T waves. It's really depressed. It looks very strange. And that's actually an indicator of myocardial ischemia. So part of the heart is not functioning correctly because it's not getting enough oxygen. And this isn't a heart attack, but it's actually a precursor to a heart attack. So if this ischemia goes on long enough and it's severe enough, this could lead to death of the cardiomyocytes, the heart cells, and that would in fact be a heart attack. So this would be a big warning sign that there's something going wrong in this person's heart. in this figure from your book, we can go through the ECG and at the same time look at the events that are occurring in the heart. So remember that these are electrical events, they're not the contractile events. All right, the first wave is the P wave. So you start with atrial depolarization, do this action potential traveling or propagating through the atria. At about the point when half the atria are depolarized, that's when you reach the peak of the P wave. By the time you reach the point where the atria are fully depolarized, that's the end of the P wave. It's now the wave has come back down to the baseline. Now, recall that there's a little bit of a delay, and that occurs because the action potentials are transmitted from the SA node to the AV node or atrioventricular node. And there, the conduction of action potentials is very slow. So there's a bit of a built-in delay before the signal is then passed to the ventricles through the bundle of His. And so there's a little bit of a quiescent period here where it's quiet. And then eventually the signal is passed down to the bundle of His, to the bundle branches, and then to the Purkinje fibers. And they start to activate or depolarize the cardiomyocytes in the two ventricles. And so a wave of depolarization, which is an action potential, starts to travel up, starting at the apex, up the ventricles. And so this is a large electrical event, and this gives us this very large QRS complex. Now, by the time you've actually fully depolarized both ventricles, then the QRS complex is over, and you're back down to baseline. And then the next event is eventually you have the T wave, which corresponds to the ventricular repolarization. And the repolarization starts at the apex of the heart and moves up. And so at about the peak here, about half the ventricles have repolarized. And by the time you get to the end of the T wave, the ventricles have been completely repolarized. So again, note that for the atrial repolarization, that event is missing. It really is in there, but it's mixed in with the QRS complex, and because the QRS complex is so big, which corresponds to the ventricular depolarization event, you just simply don't see the atrial repolarization. This figure shows the relationship between the pressure changes and the ECG. Recall that the ECG only shows electrical events and doesn't actually show the contraction, whereas the pressure shows us the result of contraction. So for example, we can look at here, we'll see the P wave. Recall that is the atrial depolarization. So occurring with a little bit of delay after the beginning of the atrial depolarization, we have atrial contraction. And we don't actually see the atrial pressure here. What's being plotted is the pressure within the left ventricle, and you see it increases with a little bit of delay. So this gives us a pretty good idea of when the atrial contraction is occurring. So it's occurring with a little bit of a delay after the P wave. Now after the P wave, the electrical signal or action potential travels from the SA node to the AV node, and from there to the bundle of His. It enters into the ventricles. And then we have the electrical event, which is the QRS complex, which is the depolarization of the ventricles. And with a little bit of a delay after that, you have the contraction of ventricles, and that contraction will lead to increase in pressure within the ventricles. So for example, here, if we look at the left ventricle, you see that the pressure increases dramatically. So the pressure actually gives us a good indication of when the contraction is occurring. And again, as you can see with excitation contraction, the excitation always occurs first, and with a little bit of a delay, then have the contraction. The only other thing I really want to note about this figure is, again, you can see the opening and closing of valves as sounds. So for example, the opening is always silent, but the closing of valves, which leads to sort of this turbulent flow of fluid, and the fluid particularly as it's stopped, it sort of causes a reverberation that leads to a sound. So the first sound, S1, is the atrioventricular valves closing, and that occurs because the ventricular pressure, let's examine the left side of the heart, the left ventricular pressure becomes higher than that of the left atrial pressure. And remember, those one-way valves are opening and closing in response to pressure differences. So if the pressure is higher in the left ventricle compared to the left atrium, then the atrioventricular valve on that side, which is called the mitral valve, will shut. Simultaneously on the right side of the heart, the same thing is happening, and that's called the right atrioventricular valve, or also called the tricuspid valve. So that's going to shut at the same time, and you'll get this first heart sound, and that's referred to as lub. And then the second sound occurs once the pressure within the left ventricle falls below the aortic pressure. That occurs a little towards the very end of systole. Remember, systole is the contraction of the ventricles. Now, the pressure does decrease during that time because at the very end of contraction, a lot of the blood is already exited from the ventricles, and so the pressure can't be maintained, even though it's still in systole. And at that point, right towards the very end of systole, the atrial pressure will actually be higher than that of the aortic pressure. Sorry, the aortic pressure is actually higher than that of the left ventricular pressure. And therefore, the aortic valve will shut. Now, on the right side of the heart, something very similar is going on, and so the valve within the pulmonary trunk will shut. And again, you have this sort of a little bit of chaotic flow of fluid, and as the valve shut, the fluid suddenly has to stop. It was moving, and then it suddenly stopped, and it reverberates a bit, and that causes a sound that's generated within the heart. And that's going to be the second sound, and that's referred to as dub, or sometimes as dup. And that occurs when the semilunar valves shut. Here are the take-home messages. We have a heart wall that's composed of 3 layers. The outer layer is called the epicardium. That includes essentially fluid between 2 layers, and that lubricates the heart and prevents it from rubbing against other organs, and so it reduces friction and protects the heart. The middle layer is the thickest layer. It's the myocardium, and that's what we actually think of often when we think about the heart. That's the main part of it. It's the muscle fibers. And then there's a very thin layer called the endocardium, which is the endothelial cells that are continuous with the endothelial cells of the arteries and veins and capillaries and so forth. So that's 1 cell layer thick. And just in between the endocardium, it's part of the endocardium, this inner layer, but between this endocardium and the myocardium, you also have a layer of collagenous, collagenous fibers. They're made out of collagen, and also elastic fibers made out of a protein called the elastin. The contraction phase of the cardiac cycle is called systole. The relaxation period is called diastole. And a very important parameter that we'll talk a lot about is the average pressure during a cardiac cycle. And this is referred to as the mean arterial pressure, or MAP. The regulation of the mean arterial pressure is extremely important in our bodies. And there's a number of things that influence it. One is blood volume. So an increase in blood volume will lead to an increase in blood pressure. An increase in heart rate will lead to an increase in blood pressure. It's not mentioned here, but an increase in the heart contractility will also lead to an increase in blood pressure. An increase in blood viscosity, which is unusual, but it could happen in certain situations, such as extreme dehydration. You might then have an increase in blood pressure. You can also have an increase in blood viscosity sometimes with athletes that take certain drugs that will increase the hematocrit, the amount of red blood cells in the blood. Increased stroke volume. Stroke volume is the amount of blood that's ejected per heartbeat. An increase in that, which is often due to increase in contractility. It's a little complicated because it also depends on things like the amount of blood that flows back to the heart, and which influences the end diastolic volume. But anyway, anything that would increase stroke volume would then also increase blood pressure. An increase in total vascular resistance, which is also referred to as total peripheral resistance, will also increase blood pressure. Another thing that it changes that is very important is that the pacemaker of the heart is the SA node, and the heart rhythm is actually generated by the heart itself. So it's said to be myogenic. The heart would beat perfectly well without any input, any innervation from nerves. But it is under control, and we talked about this. So the sympathetic nervous system will release norepinephrine, which has an excitatory effect on the SA node and will increase the heart rate. The parasympathetic nervous system, which is another division of the autonomic nervous system, will release acetylcholine onto the SA node at synapses, and this will have an inhibitory effect. It will decrease the heart rate. Finally, we looked at recordings of electrical activity of the heart during the cardiac cycle, and this is called the electrocardiogram, and we explored how you can use that as a diagnostic tool, specifically if you use a stress test. Cardiac output is the amount of blood pumped by the heart each minute. It's the product of heart rate and stroke volume. Heart rate is defined as the number of beats per minute, and stroke volume is the amount of blood ejected in each heartbeat. So that, of course, occurs during ventricular systole. Here's the equation. Q, or cardiac output, equals heart rate multiplied by stroke volume. And so the heart rate and stroke volume at rest and during exercise depend on the training state and gender. This table from your textbook shows you some of the benefits of training. So, for example, if we look at subjects that are at rest, and I'll just look at the males just to make things a little simpler. For an untrained male at rest, his average heart rate is about 72 beats per minute, and his stroke volume is 70. If we compare this to a trained male at rest, his heart rate is lower, only 50 beats per minute, and his stroke volume is higher. And that's because the heart is stronger, and so this person can eject more blood per heartbeat. And you'll notice the overall cardiac output's the same, 5 liters per minute, and that makes sense because we're imagining these two people are approximately the same size, and so they would need about the same amount of oxygen at rest. Now, if we compare what happens when we go to maximal exercise, and again, we'll just look at the males. The male is able to increase, an untrained male increases his heart rate to 200 beats per minute. Compare that to the trained male who increases his heart rate to 190. And so now look at the stroke volume. Recall for the untrained male, the stroke volume was 70. During maximal exercise, the stroke volume is increased to 110. But compare that to the male. The male's original, for the trained male, the original heart stroke volume was 100, and now it's 180. So it's really tremendously increased. So if we look at the overall cardiac output in the untrained male during very intense exercise, his cardiac output would be 22 liters per minute, which is pretty good. It's over 4-fold higher. But look at the trained athlete. His cardiac output is 34.2. So you notice that's much higher. We had 5 liters per minute in the resting state, and now we're almost 7 times higher. So that's pretty impressive. So that shows you the effects of training, particularly aerobic training, that would increase your endurance. We're next going to look at the regulation of heart rate. The parasympathetic nervous system regulates heart rate via the vagus nerve, and its job is to slow the heart rate by inhibiting the SA node or sinoatrial node and the AV node of the heart. So the pacemaker of the heart is the sinoatrial node, but the AV node is actually very important also because action potentials will travel through these internodal pathways shown in yellow here to the AV node. And then there's a delay where the propagation is slow at the AV node before the signal passes into the ventricles via the bundle of His and then goes to the bundle branches and the Purkinje fibers and so forth. So the AV node is actually quite important also in terms of transmitting this action potential. And so what you'll notice in this diagram is that we have parasympathetic output that leaves the medulla, which is the lower brainstem. This is shown in transverse section. So this output is in axons, which are within the vagus nerve. And then you'll see there are direct nerve endings at synapses onto modified cardiac myocytes, so the SA node, as well as the AV node. And so this will affect the speed of the rhythm. It'll slow, these nerve terminals release acetylcholine. This acts as an inhibitory transmitter at these synapses and will make the heart rate slower. In addition to the parasympathetic nervous system, the sympathetic nervous system also has an effect on the heart rate. It can accelerate the heart rate via cardiac accelerator nerves, and it can also stimulate the heart, the ventricles, to contract with more force. So if we look at the effect on heart rate, we can see that there are sympathetic neurons that leave the spinal cord, and they make a synapse with yet another sympathetic neuron that will then release norepinephrine at the SA node and norepinephrine at the AV node. Now, the SA node is the pacemaker, so this will increase the heart rate, and the effect on the AV node is a little more subtle, but it will decrease the conduction time at the AV node. And this is necessary when the heart rate increases. You need less of a delay at the AV node. Now, these sympathetic nerves also directly contact the cardiomyocytes that are involved in contraction of the ventricles, as you can see here. And this will increase the contractility, or in other words, increase the force of contraction, thereby increasing the force with which fluid is ejected during ventricular systole. As an athlete transitions from a resting state to low-intensity exercise, the first thing that happens is there's a decrease in parasympathetic tone. So when we think about the parasympathetic and sympathetic systems, we often describe it as, well, it's either fight or flight or rest or digest. And, during fight or flight, the sympathetic nervous system would be very active, and the parasympathetic system would be much less active. During rest and digest, the parasympathetic system would be very active, and the sympathetic system would be less active. In reality, most of the time, you're not at those extremes. And in fact, both systems are on and continuously active. So these neurons are active, they're generating action potentials, neurotransmitters being released, and so forth, and hormones are being released. So what you have is essentially is what's called tone, meaning that, for example, the parasympathetic nervous system is essentially turned on at all times, and it's generating a certain amount of activity. As you transition from, say, resting to, so if we're at rest, we have a lot of parasympathetic tone, and that contributes to the low resting heart rate. But now as we transition to, say, the onset of exercise and you're just warming up, there's going to be an initial increase in heart rate, and that's due to withdrawal of the parasympathetic activity. In other words, the parasympathetic activity will still be there, but it'll decrease. The action potential frequency will go down. And so this naturally, so remember, the parasympathetic nervous system leads to slowing of the heart rate. So if this parasympathetic activity goes down, then the opposite effect will occur. So the heart rate will go up. So it'll naturally go up to about 100 beats per minute. Later, as the exercise, say, becomes more intense, there's need for sympathetic nervous system stimulation. So those sympathetic neurons within the sympathetic nervous system will now increase their firing rate more, and that will increase heart rate even more, above 100 beats per minute. So let me just quickly recap some of the things we talk about. So when we talk about the sympathetic nervous system, there is norepinephrine that's released directly at the SA node and the AV node, and that has effects on the heart rhythm, the rate of the heart rate. Norepinephrine is also released by the sympathetic nervous system directly at synapses onto the cardiomyocytes of the ventricles, and that leads to more enhanced contractility. Epinephrine and norepinephrine are also released as hormones, and that's by the adrenal glands. And those hormones actually have very similar effects. They're also going to affect the SA node and increase the heart rate, and they'll also, both of those
hormones will also have an effect on contractility of the heart. So for someone who has a heart disease, an increase in heart rate can actually potentially be damaging. In other words, when the person's relaxed, they have sufficient blood flow to, say, the coronary arteries, even if the coronary arteries are partially blocked. But when they start exercising, the heart rate goes up, then the heart starts to metabolize more oxygen. And so at that point, you may actually have ischemia, where there's not enough oxygen to keep up with demand. So one way of treating this is with beta blockers. So beta blockers compete with epinephrine and norepinephrine at beta adrenergic receptors in the heart. So in other words, beta blockers are antagonists. They will bind to the same receptors, but they don't activate the downstream effects that would normally happen with epinephrine and norepinephrine, which are agonists for these receptors. So this will reduce heart rate if you're taking these beta blockers, and it will also reduce heart contractility, and therefore you have a lower myocardial oxygen demand, and therefore that you won't have cardiac ischemia. So these drugs, beta blockers, are prescribed for patients with coronary artery disease and hypertension. And the idea is they'll lower the heart rate during submaximal and maximal exercise. And so one thing to keep in mind is that if you're, say, prescribing exercise, or you're interpreting the results of an exercise test on a person who's actually taking beta blockers, you should take this into account. So for example, you would have to, for example, if you look at the maximal heart rate and you figure in the age and so forth, there are charts that tell you what the maximal heart rate should be. But if this person is taking beta blockers, then their heart rate really couldn't get as high as you might expect based on their age. And also, if you were to test them with some sort of stress test where you gradually increase the exercise intensity, the beta blockers will actually inhibit changes in heart rate and contractility. So you may not see the results you'd be expecting. It should be noted that the beta blockers, in some sense, they're not as popular as they once were. They used to be one of the first medicines that people would prescribe for someone with, say, coronary heart disease or hypertension. Now they're not, and one of the reasons is actually this problem with exercise. If a person's taking a beta blocker, it makes it very difficult for them to exercise. And by exercise, I'm not talking about sprints or something. I'm talking about even just walking up a steep flight of stairs could be considered exercise for someone who's elderly. So that could be really problematic. It could really limit what they can do in life. And so instead of beta blockers, there are many other types of drugs that are now used that may reduce. They won't necessarily change heart rate the way beta blockers do, but they can reduce the contraction force of the heart and things like that. And so that will, again, lower the myocardial demand. So it turns out there's a very interesting way we can look at the health of the heart that's non-invasive. What we can look at is heart rate variability. So recall that we can measure the time between heartbeats by measuring a given point. A convenient point would be, say, the peak of the R wave to the next R wave. We measure that, and let's say it's 0.8 seconds, and then we would measure the next interval, and so forth. We can then look at the variability in those periods by taking the standard deviation of this R to R interval. In healthy people, there's quite a bit of heart rate variability. And the reason for this is there's a balance between the sympathetic nervous system and the parasympathetic nervous system. And this is referred to as the sympathovagal balance. So normally, moment to moment, the sympathetic nervous system might be a little more activated, the parasympathetic nervous system more activated, and so forth. And so there's a tug of war between the two. And you get a natural variability that's healthy. There's a relatively high heart rate variability, and that's considered perfectly normal and healthy. Now, if you have a person that has a problem with this balance between the sympathetic nervous system and the parasympathetic nervous system, then you'll find that they'll have a lower heart rate variability, or HRV. And this signals that there's a risk for cardiovascular disease. In fact, if you look in patients with existing cardiovascular diseases, a low heart rate variability is a predictor for cardiovascular morbidity and mortality. Let's talk a little bit more about what causes the lower heart rate variability. Again, as I mentioned, there's a balance between the SNS, the sympathetic nervous system, and the parasympathetic nervous system. As a person gets older, or if they have a disease state, there will be a decrease in parasympathetic tone at rest. Remember, the parasympathetic nervous system should be relatively active when a person is at rest. And this decrease in parasympathetic tone can lead to a decrease in heart rate variability. Alternatively, again, with advancing age or a disease state, there may be an increase in sympathetic nervous system activity. So if that increases, that can also lead to a decrease in heart rate variability. So a number of disease states have been associated with a decrease in heart rate variability: depression, hypertension, heart disease. If a patient has just had a myocardial infarction or heart attack, they may have a reduced heart rate variability. And also, reduced heart rate variability is associated with physical inactivity. And it's been shown that exercise is very good in the sense that it increases heart rate variability. Recall that the goal of a lot of this regulation we're talking about is to maintain the mean arterial pressure relatively constant. And that was important because we need that pressure to have sufficient perfusion of various organs in our body. And one of the factors that's important for that pressure is the cardiac output. The other factor was the total peripheral resistance. Now, again, drilling down a little further, the cardiac output is dependent on heart rate. It's also dependent on stroke volume. In fact, it's the product of those two variables. So what's very important for your body is to regulate the stroke volume. And there are three factors that are principally responsible for regulating stroke volume. One is the end diastolic volume, or EDV. That's the volume of the blood in the ventricles at the end of diastole, and that's referred to as preload. We'll come back and talk about more of that more in a second. And then we're going to move on. The next thing is the average aortic blood pressure, or this is the same thing essentially as mean arterial pressure. So this is the pressure that the heart must pump against to eject blood, and that's often referred to as the afterload. Again, we'll talk more about that in a second. Finally, the third thing is the strength of ventricular contraction, which is referred to as contractility. This is enhanced if there's circulating epinephrine and norepinephrine. So these circulating hormones released by the adrenal glands will increase contractility. And recall there's also direct sympathetic stimulation of the heart cardiomyocytes in the ventricles by norepinephrine. So those are actual synapses made where norepinephrine is released as a neurotransmitter, and it has a direct stimulatory effect, increasing contractility of the heart. And we'll take each of these topics and dive a little bit deeper into all of them. The end diastolic volume is very important for a few different reasons. One is simply the more volume you have of blood in the ventricles during diastole, the more blood you can eject later in systole. But there's another interesting mechanism that we should talk about, which was determined by two different physiologists, Frank and another physiologist named Starling. And this is referred to as often as the Frank-Starling mechanism. And what they found independently was the greater the end diastolic volume, the more forceful the contraction by the ventricles. And they found that this was due to stretch of the ventricles. So in other words, as the blood filled the ventricles, it would stretch the cardiomyocytes, these are the contractile cells, and that would actually make them contract more forcibly during systole. And this, of course, the filling of the ventricles is dependent on venous return. So we'll talk about that more in a second. So let's look at this graph for a second. We can see here the ventricular volume as it increases. Then there's an increase in stroke volume. So for example, we could take a heart of a person who's resting, here's the normal resting value for the ventricular volume at the end of diastole. And we would get a certain stroke volume. Now, as the end diastolic volume increases, there'll be an increase in stroke volume. And so it's the increased end diastolic volume is because of increased venous return. Typically, more blood is coming back. And so what we're seeing here is that there's a curve in which, as we fill the ventricles with more blood, they respond by having a bigger stroke volume, which is good, because otherwise the blood would essentially have a back of a blood. There'd be too much blood in the heart. So in other words, another way of stating this is that as we return blood to the heart, it's always able to pump that blood out. And so one way of looking at the stroke volume here is that this increase in stroke volume is actually, in some ways, an indirect measure of contractility. Contractility is going up as we increase the end diastolic volume. It turns out with cardiac muscle, the more you stretch it, the greater the force that's generated by the cardiac muscle. And this increase in force is due to greater cross-bridge formation. If you recall, with skeletal muscle, the amount of force was directly related to the number of cross bridges that could be formed between the myosin and actin filaments. And it's exactly the same situation with cardiac muscle. So for example, if we could look at cardiac muscle at a normal resting length, there's a bit of overlap between the myosin fibers and the actin fibers. And so when you start cross-bridge cycling, you'll get a certain amount of contraction, and then you get into this state where the muscle is contracted. But it turns out that you notice that with cardiac muscle, there's an overlap here of the actin fibers and so forth. So it almost looks as if it's like a skeletal muscle that's been contracted already, pre-contracted before you do the test to see how much tension or force can be generated. And so you actually get better contraction. You get an increased force of contraction if you stretch cardiac muscle a bit. So this is a little bit unlike skeletal muscle. If you take skeletal muscle and you have it at its normal resting length, well, that's going to give you the best force generation. But if you take cardiac muscle and stretch it a bit from its normal resting length, then you're actually going to get more force generated. And that's because there's more good overlap between the actin and myosin filaments without any interference, with things like, for example, you might get interference here showing the myosin would actually bump into the Z discs at the end. Here, for example, you see some possible interactions between the actin filaments that might interfere a little bit with contraction. Now, you notice on this axis, on this graph, for example, we're seeing ventricular end diastolic volume. So as it goes up, there's an increase in stroke volume. I've been talking about contraction strength, but stroke volume is a pretty good substitute for that. In other words, the higher the stroke volume, that gives you an indication that there was a more forceful contraction. In the previous few slides, I mentioned that the end diastolic volume is principally determined by the venous return. And there are three things that are going to determine venous return. There's venoconstriction, which we'll talk about, and that's via the sympathetic nervous system activity. There's something called the skeletal muscle pump, and we'll talk about that in more detail. And then finally, the respiratory pump. So venous return is increased by venoconstriction, and this occurs through activation of the sympathetic nervous system. The sympathetic nervous system has nerves that send branches to small arteries that are referred to as muscular arteries. They're also referred to as distributing arteries. They distribute blood to the various organs, and they're muscular. They have smooth muscle associated with them that are under sympathetic control. So if there's activation of the sympathetic nervous system, this will lead to vasoconstriction, and that will restrict blood to a particular organ. Even more important is sympathetic innervation of arterioles. Arterioles are the very smallest arteries just before you get to the capillaries. They can also vasoconstrict and dilate. Sympathetic activity will cause vasoconstriction of arterioles. And so these can essentially direct blood to different organs, and it can also increase the total vascular resistance, which we talked about earlier. Now, on the other end, first of all, capillaries don't have any smooth muscle associated with them. By the time we get to venules, there are smooth muscle again. So these are the very small veins, and then veins have smooth muscle. So sympathetic vasoconstriction occurs due to release of norepinephrine at these terminals onto venules and veins. And when you constrict them, what happens is this actually improves venous return. And the reason is that most of your blood, about 70%, is actually found at any given time would be found in your veins, and particularly these large veins that are leading back to your heart. So if you constrict those, then the blood is sort of squeezed, and that there's less sort of area for the blood to rest. So it's in a sense it increases the blood volume. It doesn't actually increase the blood volume, but it increases the pressure, and it squeezes the blood, and it forces it back to go back to the heart rather than spending a little bit of time in these veins, which are sort of like a reservoir for blood. And so this will increase venous return, so the blood will enter into the right atrium and so forth, go through the heart. Now, if you compare the arteries and the veins, you'll find that the blood pressure in the arteries is very high. Remember, the mean arterial pressure in the major arteries was about 100 millimeters of mercury. If you look in the major veins, the blood pressure is only about 2 millimeters of mercury. So it's very, very low. So it is positive, so it'll help it go back to the heart, but it's really not enough. Particularly, it's not enough to counter the effects of gravity. For this reason, we have what's called skeletal muscle pumps. So within your legs and within your arms, you have chambers that are formed this way. Within veins, you'll have valves, which are one-way valves, and they'll form a sort of small chamber. And the way these valves work is if the pressure is higher on one side of the valve will open, the blood will flow through. If the pressure is higher on the other side, the valves are shaped like little cups. And so in this diagram, if the pressure is higher in this chamber above the chamber down here, then the blood will flow into these cups, these cusps, and then that will force this valve to be shut. Now, how does the blood actually get forced back? Well, the valves prevent the backflow of blood, but we need to now somehow force the blood forward and back up to the heart and upward. So the way that happens is some of your major veins in your legs are actually situated between skeletal muscles, so that if you're active, then there'll be a squeezing motion on the veins, which will increase the pressure, therefore opening the valve and pushing blood from one chamber to the next. And in this way, as you're running or walking, blood is very effectively pumped back towards the major veins in the abdomen and thorax. So far we've been able to get blood back into the abdomen and thorax, but it still has to make its way all the way back to the heart. So venous return is also increased by something called the respiratory pump. If you look at the inferior vena cava, it goes through the thorax and then, the abdomen and then the thorax. And it also has one-way valves like the ones we just described. Now, as you breathe, what happens is as you breathe in, you flatten the diaphragm, which is skeletal muscle. So it goes down. This increases the abdominal pressure, but it decreases the thoracic pressure, the pressure within the thoracic cavity. And so if you increase pressure in the abdominal cavity, but decrease it in the thoracic cavity, then blood in the inferior vena cava will be able to move up. And so this happens over and over. As you're breathing, you have these pressure changes, and also you have these one-way valves, and therefore blood is able to move upwards fairly continuously when you're exercising, as long as you're breathing steadily. Now, this effect is relatively small if you're resting. It's there when you're resting, but if as you exercise and you breathe really deeply and with a lot of force, this respiratory pump becomes even more effective. And so it's really a major way that blood is brought back to your heart, particularly when you're exercising. As a quick reminder, what we've been talking about the regulation of stroke volume. And up to now, we've really just mostly been focusing on the end diastolic volume, all the things that help to increase the end diastolic volume, which is also referred as preload. The next topic we'll go into is the average aortic blood pressure, also referred to as mean arterial pressure. And we'll look at its effects on the regulation of stroke volume. Basically, it's going to create what's called an afterload, and the higher the average aortic blood pressure, the more difficult it will be for the heart to eject blood. Let's look in a little more detail at the average aortic blood pressure and how it affects stroke volume. So this average aortic pressure is the same thing as mean arterial pressure, and it's referred to also as afterload. So what this is essentially pressure that the heart must work against. So for example, if the heart is going to eject blood, the only way it can eject blood is if the pressure within the ventricles is higher than the pressure in the aorta. So during the ejection phase, it has to be higher. And if there's a very high afterload, meaning, for example, if you have a patient who has a high systolic blood pressure, then that would essentially work against the heart. It'd make it more difficult for the heart to eject a certain amount of blood during the ejection phase. And so this is actually a real problem. Is in a person with hypertension or very high blood pressure, the heart has to work harder to overcome this pressure, to push against it, to eject blood. There are some good things, though, which is recall that mean arterial pressure is equal to cardiac output multiplied by the total vascular resistance. So when you're exercising, then things are sort of reversed a little bit. So during exercise, there's dilation of the arterioles and skeletal muscle, because remember, we need to bring more oxygen and nutrients to the skeletal muscle. And this naturally is going to decrease the total vascular resistance because the arterioles are a major part of the control of total vascular resistance. So when there's vasodilation, that goes down and more blood flow happens. And so if the total vascular resistance goes down, for a given rate of cardiac output, you'll see that the mean arterial pressure goes down. And so that means that during exercise, you actually have a reduction in afterload. And this may help with allowing the ventricles to then eject blood, and it will actually increase the stroke volume. The third factor that affects the regulation of stroke volume is the strength of ventricular contraction, also referred to as contractility. There is enhanced contractility when you have circulating epinephrine and norepinephrine, those hormones. And there's also direct sympathetic stimulation of the heart by norepinephrine. So remember that norepinephrine can affect the SA node and the AV node, and thereby increase the heart rate. Norepinephrine released at synapses from sympathetic nerves directly onto the heart. Cardiomyocytes in the ventricles can also lead to an increase in contractility. The stimulation of the heart increases both, as I said, the heart rate as well as contractility. And you can see this in this graph. So for a given ventricular end diastolic volume, if you have sympathetic stimulation, you'll get a larger stroke volume. And that's entirely due to this increase in contractility. And you'll see that for any given ventricular end diastolic volume, if there's sympathetic stimulation, you'll always have a higher stroke volume. And again, that's because of this enhanced contractility. We can now summarize some of the things we talked about that regulate cardiac output. And remember, cardiac output together with total vascular resistance determines the mean arterial pressure, and that's this incredibly important variable. It's a regulated variable, mean arterial pressure, that your body senses via baroreceptors. So cardiac output is incredibly important. It's dependent on the cardiac rate. So this dashed line indicates inhibition. So parasympathetic nerves innervate the SA node and the AV node, and they release acetylcholine, and this has an inhibitory effect, and it reduces the cardiac rate. Sympathetic nerves, which originate from spinal motor nerves at the level of spinal cord, they will release norepinephrine at the SA node and the AV node and have an excitatory effect and increased cardiac rate. If we look at stroke volume, well, sympathetic nerves also affect them. They make direct synaptic connections with the cardiomyocytes in the ventricles, release norepinephrine, and increase contractility. Another thing that affects stroke volume is the end diastolic volume. So the larger the end diastolic volume, the greater the stroke volume. And a lot of this effect has to do with the stretch of the cardiomyocytes and the ventricles by having that increased volume. And cardiac cells are a little bit unusual in that they contract with more force when they're a bit stretched. And so that's, again, feeding into this. If you have a stretch of the cardiomyocytes and the ventricles, they'll contract with more force, and therefore there'll be an increased stroke volume. And finally, the mean arterial pressure also has an effect, and this is indicating an inhibitory effect. The higher the mean arterial pressure, the higher the afterload. That's the load that the heart has to work against to eject blood. And so this is a problem with patients with hypertension. If there's a very high mean arterial pressure, then the ventricles, and particularly the left ventricle, which goes to the systemic circulation, has to work very hard. And you may get into a situation where you'll have hypertrophy, meaning that the muscle actually grow thicker and stronger, but that only works up to a certain point. At some point, you can actually have muscle weakening due to that. And again, finally, another point was that during exercise, very conveniently, there's increased blood flow to the skeletal muscles due to the fact that there's vasodilation of the arterioles leading to these skeletal muscles. And that will decrease the total vascular resistance, TVR. And that actually reduces the mean arterial pressure, which is the product of cardiac output multiplied by TVR. And so that's actually helpful because you're reducing then some of the afterload, and it makes it easier then for the heart during exercise to eject blood. Here are our take-home messages. Cardiac output is the product of heart rate and stroke volume. So Q is the cardiac output. It equals heart rate simply multiplied by stroke volume. The pacemaker of the heart is the SA node or sinoatrial node. The SA node activity is modified by parasympathetic nervous system. It slows down the heart rate via the release of acetylcholine, and the sympathetic nervous system increases heart rate via the release of norepinephrine at synapses on the SA node. Heart rate increases at the beginning of exercise due to the withdrawal of parasympathetic tone. So normally we all have parasympathetic tone, meaning that our parasympathetic nervous system is active. So the nerves are generating a certain number of action potentials or nerve impulses at a certain rate. As you start the exercise, that parasympathetic tone will go down, so there'll be a lower firing rate. And that'll lead to an increase in heart rate up to about 100 beats per minute. And then as the exercise intensifies, then you have more increased sympathetic outflow, which will then affect the SA node and increase the heart rate. Also, stroke volume is regulated by end diastolic volume, afterload, which is the aortic blood pressure, and the strength of ventricular contraction. Venous return increases during exercise due to venoconstriction, the muscle pump, and the respiratory pump.